Now coming to the progesterone. Progesterone has a ANP, atrial natriuretic peptide like effect. It will cause natriuresis, not sodium retention, is what we need to fundamentally appreciate. Now shoot me an answer, doctor. You are the interventional cardiologist from there, Stanford Institute of Interventional Cardiology. Now tell me, how much LV hypertrophy in mm and what valve area less than how many centimeters square you like to post your patient for aortic valve replacement? Let me see how many interventional cardiologists are there in the online community. Our Warangal students say less than 2.5 centimeters square. Guntur also agrees with 2. Yes? What is your proposition? Give some wild guess, because valvular heart disease may, one of the favorite questions of the examiner is, what diameter you call mitral stenosis severe, moderate, mild, aortic stenosis moderate, severe, mild. At least these 2 valves you have to remember. What time you can do balloon valvuloplasty and when you want to do valve replacement. These 2 decisions you must know. Right? Ultimately tomorrow when you are a cardiologist, everyday job is the same thing. Your resident will come and tell, sir, we have done the procedure and we found this is the valve diameter. Then your cardiothoracic surgeon's job is to do a valve replacement. So your party, your role is what then? Participating in the evening party hosted by the what you call stunt company, right? So yeah, let me see. Vizag students say 6 mm and 1.5. Tirupati say 5 and 2. So doc, 15 mm LV thickness if it is there, or less than 0.6 centimeters square, it becomes an indication for valve replacement, is what you have to remember. Now, lot of patients, incidentally when you check may have bicuspid aortic valve. Incidentally, 40-year-old, 35-year-old, your own classmates in a medical college can have bicuspid aortic valve. A very good number of patients can have calcified aortic valve. But aortic stenosis will be asymptomatic in these people. Why? Because when aortic valve is stenotic, what will left ventricle will do? It will do more hard work. If the November only NEET is conducted, we will do more hard work. That's what left ventricle will decide and start working. But the moment hypertension also supervenes, after 40 everybody will get, a good number of people will get hypertension. When hypertension also is throwing load on the LV, on the top of it aortic valve is very narrow, then 2 problems means very difficult. If you get acute medical care or casualty posting in October and November is the NEETPG entrance, together they come together, means best thing is go to the casualty and work with the patients and use common sense in the exam hall. Probably you may get seat instead of preparing. So if 2, 3 troubles come together, we can't do anything, right? So lithium, what does it do? It can lead to nephrogenic diabetes insipidus. If you look at the adrenergic receptors, beta 2 are more sensitive to the epinephrine than to the norepinephrine. It is the anterior hypothalamus which brings all that heat within our body, and posterior hypothalamus makes us to shiver and get rid of the heat. So they are the 2 important things that need to be remembered. Whenever optic chiasma is compressed, then what is going to happen? Bitemporal hemianopsia is a very common problem. Now doctor, 2 pages in Genong in respiration chapter, Genong or any book, physiology book. Respiratory regulation. What is apneustic center? What is pneumotaxic center? What are dorsal and ventral respiratory neurons in medulla? What is their function? Today only you should read. So that's the reason we decided every Wednesday, Sunday we conduct a test. So we will draw based on the previous DNB question bank, screening test question bank, which is the typical DNB style of asking questions. We will come up with 500 topics which are going to surface in tomorrow's exam, one list. So every time when you come, we will give you some 50. All 500 we give on the day one only. You will say, what is a big deal in this, sir? Everything in the book is in this 500 topics. Who will read? So 50 topics we will release every Wednesday, Sunday when you come to the discussion. So limit your plan also to 500 topics, because time is limited. If you at this time, if you think of living a king size life, it is difficult, because time is the whole constraint here. It's not the depth of knowledge which is tested now, it is the width of the knowledge that you have. How many topics, at least once you touched them, is all about the challenge of the 2 months preparation. And don't say, our 3-year-old seniors are there, 4-year-old seniors are there. Remember, 3-year, 4-year, 10-year-old seniors also will read in the last 3 months only. So that is the reason, don't worry about if you are the first time taker, don't worry about your seniors already read everything. No. So remember, doctor, apneustic center is in the lower pons. It has an intrinsic rhythm. Whenever it is stimulated, it will prolong the inspiration. Hence, apneustic breathing is an abnormal breathing pattern. Where is pneumotaxic center located? It is in the upper pons. It will inhibit the effect of apneustic center and upper pons, lower pons. But otherwise, these two centers are located in the pons only. So what is the role of these two centers? Apneustic is father-in-law, pneumotaxic is mother-in-law. And they have a daughter-in-law, no, naturally. Who is that? It is basically medulla. Medulla, in medulla, there is a husband and wife, son and daughter-in-law. Who are they? Where are they? Dorsal respiratory group. What it will be doing? Inspiratory respiratory rhythm based on the input from the vagus and glossopharyngeal nerves. If they say, Papa, we want more school fee and uniform and more money, then dorsal respiratory group, after receiving, these are the children, grandchildren, vagus and glossopharyngeal. So they tell, all our classmates are going to America as a school trip. Dad, pick up 75,000 rupees from your pocket. So dad is dorsal respiratory group. Then what is ventral respiratory group? It innervates both inspiratory and expiratory movements, but mainly responsible for expiration. And only during exercise it becomes active. So I leave the literature for you, but this literature given in the notes is not enough. Textbook is the safest place to read, doctor. Now let me shoot you a question. The level of circulating amount of which substance correlates with the severity of the LV filling pressure in a patient of congestive heart failure? Which substance comes to your mind? Whose level we can calculate to know how is the CHF patient's fluid adequacy? Guntur students have more or less correctly shot it, ANP, and Varun said BNP. That's right, BNP is the one which correlates with the severity of the LV filling pressure. What is pulmonary artery systolic pressure? 22 millimeters of mercury, whereas LV systolic pressure, all of you know, is 120 millimeters. What is inspiratory reserve volume? It is 2 to 3 liters is the inspiratory reserve volume, not 1 liter. All tidal volumes, their measurements, like a tailor going to the exam, you must remember. Now, if you compare skeletal versus cardiac muscle, what is the main difference? Compared to skeletal muscle, cardiac muscle contains lesser number of T tubules, but even those lesser number have wider diameter compared to the skeletal muscle. Skeletal smooth and cardiac muscle structure you need to know the main differences. Now coming to the arterial pressures, two values you should know, doctor: mean arterial pressure and pulse pressure. What is the difference between the two? The mean arterial pressure is calculated by adding diastolic pressure plus 1/3 of pulse pressure. How do you get pulse pressure? Systolic minus diastolic pressure is pulse pressure. So systolic 120, diastolic 80. 120 minus 80 is 40. 1/3 of the 40 is 13. 13 plus 80 diastolic will make it 99. Becomes the mean arterial pressure. But the difference between systolic and diastolic pressure, which we call pulse pressure, it depends on what? It depends on two factors. One is stroke volume, other is how compliant are the blood vessels. Elderly person, very calcified vessels, not ready to distend when the blood is pumped. So what will happen in them? Systolic BP will be high, and hence systolic minus diastolic, the pulse pressure typically become increased. With the increase in stroke volume and increase in decrease in compliance with an aging person is what need to be remembered. Now, coming to the exercise physiology, what happens when we are exercising? Liver flow, kidney flow, visceral flow, splanchnic and renal blood flow will decrease selectively, and the skeletal muscle blood flow will increase, is what need to be remembered. Now, tell me, doctor, some congenital heart diseases, they will only survive if the ductus arteriosus is patent, otherwise they won't. Hence we use prostaglandin infusion to maintain the patency of those congenital heart diseases. Why? Basically what is PDA doing? PDA is connecting aorta with pulmonary artery. Agreed? Suppose if you take a patient of TOF, in TOF what is happening? There is a pulmonic stenosis, hence the right ventricular blood, instead of flowing into pulmonary artery, is flowing into aorta, but we want it come back to pulmonary artery. For that what will you do? You maintain PDA patency so that the blood will come back to pulmonary artery until you take a definitive surgery of correcting that pulmonic stenosis and correcting that overriding aorta. Similar to TOF, tell me two more conditions. Let me see. TOF and TGA is the answer of Warangal. Transposition of great vessels from Guntur. TGV and TAPVC is answered from Kurnool. So remember, any right-sided valvular atresia, pulmonary or tricuspid atresia. If tricuspid atresia is there, how will the baby can survive? Tricuspid is between right atrium, right ventricle. If it is stenotic tightly, what will happen to the right atrial blood? Through the ASD it will flow from right atrium into left atrium. Through that it will pass. So where is the right atrial blood stolen? At the atrial level. That stolen blood must be given back to the pulmonary artery, no? Unless patent ductus is patent, kept patent, that blood which got diverted from right atrium into left atrium because of the tricuspid atresia can't be given back to the pulmonary artery, is what need to be basically remembered.